So welcome back, everyone. We will now continue with session 2, focusing on global cooperation, accountability, and sustainable leadership in public health. Chairing this session is Dr. Ian Smith, Senior Advisor to the WHO Director General and Head of the Secretariat for the Global Preparedness Monitoring Board. Please welcome our Chair, Dr. Smith, with a warm round of applause.
Thank you very, very much. I should confess I am no longer the head of the Secretariat for the Global Preparedness Monitoring Board. That's been taken on by Dr. Bruce Aylward, but I was there at the launch of their last report, and I'm going to make a plug for it. Please read it. It's a really important summary of what's needed in the world today, in a period of turmoil in health, in politics, in finance, in so many different areas. It's an important report. So please do get hold of it if you can. I'm going to be chairing this session. I'm going to try and keep it a little informal. We will, of course, be shortly inviting our keynote speaker to come forward, but I'm also going to ask the other members of the panel if they could come forward now, and we'll start with everybody up on stage, if that's okay. I'll introduce them, don't worry. Give them a chance to get up, and then I'll introduce them shortly. The reason I think I'm here is because I used to work with Dr. Lee. I first met him 29th of November, the year 2000, when he was appointed as the director of Stop TB. And I worked with him then consistently until the day of his death, 20 years ago today. A great man, a man, as we will be hearing about shortly, a man of action, a real leader. And our theme for today is around leadership, and around particularly the way in which leaders can make such a difference in global health, as Dr. Lee did in his very short time as DG. There are a number of people here who, if it wasn't for him, would not be here. I count myself among them. I think there are several others, Ginny particularly, another who is here because JW was DG. Alex there as well, a number of others. I should also, I hope Wilfred is still around. Wilfred, are you? I'm afraid I can't see it. Anyway, if Wilfred is still around, he may be coming back in. Wilfred has been in WHO, or was in WHO, I should say, from 1977. Extraordinary, eh? And he worked very closely. He was a very close friend and colleague of Dr. Lee as well. I would just like to pay tribute to him too. And many other WHO staff actually in the room here now, too many to mention, who have worked with Dr. Lee or have had the privilege of seeing him at work and have followed in his footsteps in exercising in their own way leadership in global health. But first of all, it would be appropriate for me to introduce, and excuse me again, my iPad has gone off as it always does at the critical moment when I want to be reading from it. I'm going to be introducing our keynote speaker. Our keynote speaker is Dr. Jerome Kim. Dr. Kim, please do come forward. Let's give Dr. Kim a round of applause, and please do come forward, sir. Thank you. Dr. Kim is the Director General of the International Vaccine Institute. He is a physician and a scientist, obviously specializing in this area of vaccine development and global health. And his work is really the basis for what we need in the world today, equitable access to vaccines, especially in low and middle income countries. Dr. Kim, you have the floor.
Thank you, Dr. Smith. Dr. Mohammed Abu Fayez, Excellencies, colleagues, ladies and gentlemen, thank you. This is a wonderful opportunity to pay tribute to one of the global health leaders of the 20th and 21st centuries. And although, again, I'd never had the opportunity to meet Jong-wook, I feel like as he was the person who broke ground for the IVI building, that at the International Vaccine Institute, we all owe him a serious debt of gratitude. Just to explain what IVI is, it's a UN-chartered international organization dedicated to accelerating vaccine research and development for global health. Our mission: to discover, develop, and deliver safe, effective, and affordable vaccines, empowering vaccine equity, impact, and sustainability globally. I think this mission today is one of the most important things that we can say, the empowerment of vaccine equity, which not only means working to do technology transfers, but training people in countries around the world to develop vaccine security for regions and nations. You can see where around the world IVI works. We have now a headquarters in Seoul, regional offices in Stockholm and Kigali, country offices in Austria, and just recently signed a country office agreement out in Nairobi, Kenya. You can also see the new laboratory that's opened up in Hong Kong. There are 61 now countries and WHO that have joined or are in the process of joining our international organization, and our first G7 member, Canada, joined on April 1st. So the theme of this discussion is global health leadership and Korea. And you don't necessarily always associate them, or Korea itself, with global health leadership, although it has had people who've had leadership positions like Lee Jae-wook, but also Ban Ki-moon and the Sustainable Development Goals. I mean, all of these things relate to a commitment in the country and a belief in development. Remember that Korea was colonized by Japan for 35 years and then suffered a major Cold War conflict where the capital of Korea changed hands 4 times. There are pictures of Seoul flat after the war. GDP per capita was $64 in 1955. By 2026, Korea had recovered. GDP per capita was over $37,000. And as you might expect, and you can see that in the panel to the left, Korea had started to give funding, official development assistance, starting around the late 1980s and early 1990s, and that amount has gradually increased, but the ODA to GNI ratio, ideally 0.7, is still 0.21. So Korea has a ways to go, but as with many countries that have just entered, that have gone from being dependent to being now independent and having funding available, you know, it takes a while for donors to understand, and this may be an opportunity for those countries, for the countries newly entering OECD, like Panama, like Korea 20 years ago. It takes some time to build up that history, that familiarity, that comfort with official development assistance and the work that it does for countries around the world in the same way that that same development assistance has helped Korea to develop. So Korea's progress from global health aid recipient to global health donor. Starting in the 1960s, Korea started to offer training programs to other developing country participants. So this is at a time when Korea's GDP per capita was lower than many African countries. When they were holding training in Korea, they routinely invited other countries from the region and elsewhere to participate in that training. Official development assistance started in the 80s. KOICA, Korea International Cooperation Agency, was established in 1991. The first financial contributions to UNAID started in 1996. IVI was founded in 1997. So we are the first international organization to be headquartered on Korean soil. A very important idea, but also one, if you speak to Professor Cho Won-kyu and the late Professor Sang-dae Park, they really said, we saw this as an opportunity. Korea needed biotechnology and innovation. We saw this not only as an opportunity for Korea to pay back, but to also as a way to develop the capabilities in biotechnology, which they saw as one of the next waves of future industrialization. So first contributions to the Global Fund in 2004. Then, of course, there was this period of time where Korea was using air ticket solidarity. It was less than $1 per ticket for people transiting through the new Seoul Incheon International Airport. And you'll see a little bit more about it because it really generated a significant amount of funding and allowed Korea to fully fund its contributions to other organizations. The first commitment to UNITAID, first contributions to Gavi, a new fund called the Wright Foundation, which funds innovation and the commercialization of innovation in global health technologies, vaccines, drugs, diagnostics, and digital health products for global health, with access agreements for all of these. First, financial contributions to the Coalition for Epidemic Preparedness Innovations, the founding contributions to the Pandemic Fund. So again, Korea is emerging as a donor, but as with many new donors, it needs to expand, it needs to, and now, actually, and you'll see the slides shortly, we'll need to start to think about our leadership role in this effort. So the Air Ticket Solidarity Program is interesting. Again, it was a $1 charge, kind of invisible to people, on every ticket for people using Seoul's International Airport. If you've ever been to the Incheon International Airport, it's really quite a remarkable place. It raised 425 billion won, which is about $300 to $320 million, and it was all for global health. It was really remarkable. 40% to multilaterals, 40% to multi-stakeholder projects and partnerships, such as those by the UNFPA and UNICEF, and 20% roughly to Korean NGOs and organizations like IVI for field projects in Africa. 100% of the Gavi funding came from this fund, and funding to Unitate also came from GDF. It's supported through the TB Alliance, the TBA, Surfequilin, which is a new agent for drug-sensitive and resistant tuberculosis. It funded MMV's seasonal malaria prevention study, and it supported cholera vaccination in support of generating data around the best use of cholera vaccine. So it did a lot, but unfortunately, it ended in 2024, and efforts are now in place to try and restore this fund because of the benefit that it had for global health. The next thing I'd like to speak to is what we call the Right Foundation, Research Investment Global Health Technologies. It's something that IVI, the Korean government, the Gates Foundation worked very hard to put into place. And if you have a question about how to do this, Youngmi Cho is sitting in the audience, and she was really the person at IVI who worked so hard to try and get this fund in place. But you can see that it's very much like the Global Health Technology Innovation Fund in Japan, 50% contribution from the government, 25% from Gates, and 25% from Korean companies. And since its inception in 2018, those three organizations have put in $102.1 million. On top of that, other organizations to develop these products have leveraged that with an additional $360 million. And when we think about what we need to do in global health, it's not only being more smart, it's not only about reducing our overall costs, but it's about innovative financing, thinking about ways to get other funders into the mix. And this is what the GHIT does. A 3.5 to 1 return on investment for the GHIT fund has allowed now, in the short period of time, 4 products to either be approved by regulatory authorities in Korea and now submitted to WHO for pre-qualification, an FDA-approved device, and a WHO pre-qualified diagnostic device. So these are real contributions to global health. And also then for the Korean government, it's the commercialization of innovation. It's building an ecosystem in biotechnology that the government can use that will generate jobs and innovation and IP in Korea itself. All of the grants are given with global access embedded in them, so that these are not things that are going to make billions of dollars for some company in North America. These are things that have to be, by definition, transferable and used in global health for the purposes it was intended. Official development assistance, and actually it was funny because I think he's not here today, but a former global health ambassador, I think you probably know him, said, ODA as we know it is dead. And for many organizations that depend on official development assistance, this would have tragic consequences. And so one of the things that IVI has been doing is really not only talking about what official development assistance does and the good that it does, and the people here don't need to be told what good ODA does. It helps to power schools, so it educates people, it provides vaccination assistance, it supports health services delivery, and other things. It helps to build water, sanitation, and hygiene facilities. ODA is important. One of the things that IVI has done is to look at what are the other things it does. And what are the benefits for the countries that give ODA? Because, some of the politicians are asking us, so what have you done for us? I mean, yes, we're giving money, we're helping to contribute to cholera vaccine distribution, development, generation of data, but what has it done for us? And we can say, well, look at this, the Wright Foundation. The Wright Foundation's generating products that Korean companies are making. That means Koreans are being employed. It's generating IP for Korean companies. Again, a good idea. It's the companies, QuadMed, LG Chemicals, U-Biologics, SK Bioscience, are companies that are working with the Wright Foundation to generate new products for global health. These innovations are going in to support other activities, so a secondary benefit, and leveraging good health for Korea. So there is a benefit to ODA, and it's not only to the countries where development assistance is used directly, but if ODA is used correctly, it can actually have secondary benefits for the countries that give it. And that is now, unfortunately, increasingly a common thing that we're hearing. So what is this doing for us? And we can articulate that. We hadn't thought of it that way, but as global health leaders, you're going to need to be able to look at the benefit of ODA in the countries that give it. So this is, again, IVI exists because of the government of Korea. They donated the land, which is next to Seoul National University. They built the building that IVI exists in, and this is the thing that Lee Jae-wook was involved in the groundbreaking for that building. But the things that IVI has done, the impact that we have had, is attributable to ODA, to a vision that a country that was a developing country, that became a developed country, should also make a contribution to others, to help others. So this could be the 180 vaccine development projects for vaccines for which there is market failure. Everyone thinks, the market works wonderfully. It works wonderfully in countries that have a big market. It doesn't work so well for a person who has schistosomiasis, because schistosomiasis doesn't exist in North America or in Europe. But the development of a vaccine for schistosomiasis is at the top of the list sometimes when we speak to ministers of health in Africa. Vaccine products that were pre-qualified, doses of the world's only oral cholera vaccine, lives saved from that oral cholera vaccine, vaccine tech transfers, the $450 million mobilized through the Wright Foundation. All of these things are impacts that we have. And as an international organization, we need to be able to articulate this to our funders. We have to do the work that we are designed to do, which is really around global health and improving health outcomes in low and middle income countries for vaccine preventable diseases. That is our mandate. But we also have a benefit to the countries that fund us, and we just have to make that clear. So again, cholera is one of those wonderful examples. The oral cholera vaccine was made possible by support from Korea, Sweden, and India. It's really an important thing. The IVI oral cholera vaccine, now technology transferred to multiple different organizations, may be the basis for the first new vaccine manufactured in Africa in 100 years. If BioVac's vaccine is shown to be non-inferior to the existing U-Biologics vaccine, it will be the first successful manufacturing of drug substance in Africa in 100 years. This is the meaning of development assistance. It's not only teaching people how to farm, it can be teaching people how to manufacture a vaccine, how to package it, how to test it, and then how to use it for benefit and impact in Africa. So the great unraveling in global health, I don't have to tell you this, but 150 million lives saved over 50 years by EPI programs is not enough, and are under threat. But we have the middle powers. And what are the middle powers? Because depending on the person's example, they change. Those middle powers, Korea is the #4 supplier of vaccines to Gavi. India and China supply 70% of the vaccines to Gavi. These are middle powers. If you look at the cuts that many countries are putting into place, you have this group of middle powers. And what can the middle powers do? They can innovate. So GHIT, the Wright Foundation. Why not have a global Wright Foundation, which is something that we talked about at a side event yesterday? Global Disease Eradication Fund, which is air ticket solidarity. Middle powers can cooperate. Multilateralism is more important for middle powers, which means that we know how to collaborate. Facilitate transition from a global north-dominated system to a global system. Demonstrate and facilitate functional regionalism. So not regionalism that limits passage of people and technology, but regionalism that really helps the countries in the region and other regions as well. Middle powers can advocate, and the former Prime Minister of Singapore said, even small countries have agency, meaning that you have a mouth, you have an ability to say things officially, you should say things and advocate for the things that are important for global health, because the G2 are not going to occupy that center cross. It's the middle powers who need to step in and take control. Capacitate. We know that Korea has worked to try to improve training and build capabilities throughout the world. The Global Training Hub in Biomanufacturing, which is a WHO Academy sponsored training, the basic course in vaccine manufacturing, is supported by the Ministry of Health and Welfare of Korea. So when students come, the entire cost of the course is carried by the Ministry of Health and Welfare of Korea. So all the 1,000 people who've come through the 2 different courses in training have been funded by the Korean government. Educational partnership is critical. Technology transfer, IVI has done 14 technology transfers of 6 different vaccines. Others have done the same. You don't have to be Merck or Pfizer, because they are innovation powerhouses, in order to do technology transfer for the diseases that matter for the world. And finally, and this is the hardest point, because I can say middle powers should lead, but how do you get a government to step forward? And Mark Carney said a lot of things in his Davos speech, but he did say, when middle powers work together, we can do even more than protect ourselves and our sovereignty. We can build something better, more prosperous, and more just than what came before. And Canada just joined IVI, and I think we should challenge each other now to encourage those countries that are the middle powers to really begin to do the right thing, because 150 million lives were saved by advances in vaccines and vaccination since the EPI program was established. We cannot let that fall. We have to come up with the reasons. We have to be persuasive. We have to be cogent. We have to be able to understand what the donors want. But we need to get that money, because although IVI talks about being impact-driven, we have to have the funding sometimes to do that impact. And so we all need to be better at trying to find innovative ways to work together, innovative mechanisms to fund, and better ways to get the middle powers to step up and lead. Thank you.
That was brilliant. I think that's a perfect introduction to this next section, when we're going to be hearing from our panelists as well, having a panel discussion on this issue. Thank you so much for that, Dr. Kim. I'd love for us to be able to go back to your slide at some point, your last slide, and talk about that innovation and capacitation and coordination and advocacy, because I think those are some of the key areas that we're going to be needing to work on in the years to come. But let me first introduce the other members of our panel today. After Dr. Kim, I'd like to introduce Dr. Jong-wook, who is a former commissioner of the Korean Disease Control and Prevention Agency, and a real public health expert with much experience, particularly in the area of infectious disease research and policy, but also in international health governance. And Dr. Ji is also a member of the Independent Oversight Advisory Committee for the WHO Emergency Programme, a very key role. I've then got to introduce Ginny, which is really difficult. Ginny and I have worked together in one way or another since 1997, 30 years, at different times and in different roles. It says here that the notes I was given say Ginny is a global health specialist with experience in health system strengthening. I think that's an interesting way of putting it. I would have perhaps phrased it a little differently. Ginny has probably done more different jobs in WHO than any other person in the world, I should think. Working in the TB program, working on the Global TB Drug Facility, leading that, then getting taken up by Dr. Lee to his office and to support him as his executive officer and travelling all around the world with him. And then more recently doing a huge amount of work on non-communicable diseases, particularly TB control, tobacco prevention and other NCDs, a giant in that area, just doing some amazing work. And then Iris is our new Ginny, I think, in some respects, a physician and a climate health expert specialising in sustainable healthcare and climate adaptation. And she's got a PhD, I believe, from the London School. Congratulations. Her work bridges science and policy and youth leadership, and I'm going to emphasise that bit, youth leadership, because that's really what we need in the world today, is really a real new order, in a way, of our youth who bring such new ideas and creativity and willingness to work together. Need that in the world today. And in fact, I'm actually going to start the first question to you, Iris, because I also think that's what Dr. Lee would have done. If he'd had this forum stage, he'd have gone straight to you and he'd have asked you for your thoughts. You've been working very closely with the Youth Council, with many young people who are interested in global health, who are committed to it. And you've been involved in the calls for stronger accountability and inclusion in global decision making. What do you think it will take then to turn some of the important commitments that we've got in global health? No lack of commitments. What will it take to turn those commitments into real action, the action that is equitable and inclusive and really makes the changes that we're looking for? Over to you.
Thank you so much, Ian. Hi, everyone. It's such a pleasure to be here, and thank you for the invitation, and pleasure to be also with these esteemed fellow panelists. I think it's a really important question. I have the privilege to be one of the founding members of the WHO Youth Council, and I was a youth representative before that and after that, so I've seen a huge shift, I think, in the past few years even, in how youth is engaged in these types of spaces. But I also know from my colleague, Doreen van der Waal, that Dr. Lee, I think, was a big supporter of young people. So it's very much a pleasure to be here and speak on this. When young people call for stronger accountability and inclusion, they're not asking for symbolism, but they're really asking to fill the gap between what we're saying and how we actually act. It's also about connections across generations, building in sustainability, bridging the gap between all the knowledge that's been built up and the young people that are coming into the workspace, as well as, of course, bringing in creative new ideas, because we've grown up in a world vastly different from the generations before us. If I give 3 concrete shifts that I think we need to see in global health to make this more inclusive and equitable, I would start with decision rights, not just consultation seats. We see a lot of consultation, but that's not true inclusion. So across the multilateral system, we see that young people are routinely invited to speak, to advise, also to be photographed, but rarely invited to vote, allocate, to veto. WHO Youth Council, I think, is one of the better examples where that's the first institutionalized mechanism of youth engagement at the WHO at the global level, which I think was a huge step forward. The issue is also starting to change more. We actually saw at this WHA that the Czech Republic, the Netherlands, North Macedonia, and Slovenia raised a point, actually raised by the youth delegate of Slovenia, calling for a quota in young people in the WHO workforce. So I think that's exactly the kind of pressure that we need more of. The broader shift is also structural, so standing youth seats, decision-making authority, so not just observers, but actual members of what's going on. Second shift, opening doors and also paying for the work that young people are doing. So we need to have a fund, pipelines that produce young people into these spaces. To take one concrete example, the WHO Youth Delegate Program. So in 2018, we saw that 5 member states brought a youth delegate to the World Health Assembly, meaning a youth representative and really a youth voice. This year, 24. So I see a big increase, and I'm really excited about that. But that still means that we have around 170 member states that still can make that step. So if anyone is here in the room that can contribute to that, please do. And the asks here are concrete. I think this also goes into internship programs. This goes with stipends that WHO luckily has introduced now. Donors should refuse to fund unpaid placements. Visa support should be core part of the budget, right? So these are decisions that I think can be made quickly. And finally, I would say accountability. So we need to measure. And if we measure and we look at the HR report of WHO, we see that between the age of 20 and 29 in the workforce, it's only 0.66%. So that's very low. If we measure this, and we measure this across, so also in delegations, what is the engagement? How do we see people under 35 engaging in these types of spaces? We know where we need to improve. So let's do that and let's report on it. Dr. Lee called for health for all. He didn't call for consultation for all. He called for power, access, outcomes for all. So 20 years on, I think we need to question ourselves. Are we willing to make structural financial measurement decisions that turn that vision into something a young person in 2046 will actually want to inherit? Thanks very much.
Brilliant. So the first thing you need to do is to say, everybody who's here, contact your government and ask them what are they doing to make sure that their delegation to the World Health Assembly includes young people. Yeah? Great. That's one thing that everybody can at least think about doing. And I think you're absolutely right. Dr. Lee's first comment would have been, get on with it. Just do it. Yeah. Ginny, what you've got so much experience in this area, and you know both as, we've all been young people, haven't we, at one time or another, but what will it take, not just from that perspective, what will it take to really encourage a much stronger way of working together to ensure that we can actually see that progress that we need? Words, plenty of them, but it's the action that's always missing. What's it going to take?
And that's a really great question. I mean, just before I answer the question, just a comment to our esteemed speaker. JW would have loved your presentation. He was an incredible fan of his home country and very, very proud. And to you, JW was someone who gave a lot of confidence to young people. When I was 25, he put me in charge of a $30 million drug procurement program. He didn't just give lip service to young people, he gave them real work and real responsibility. And I think that's so important. In terms of implementation, how do we make it happen? How do we bring coalitions? I think our esteemed speaker at the beginning gave us some really good clues. It's really about making sure different sectors are working together, particularly the private sector, the public sector, civil society, NGOs, governments, and increasingly cities. JW, as I always called him, Dr. Lee, my esteemed boss for 2 years, was really focused on practical action. He was a humble leader, but he really insisted always on results. I never forget once, he came to me and a group of young staff and said, "What are you doing?" And we said, "We're writing the 5-year strategic plan." And he looked at us and he just said, "Tear it up. Go and get on with the work. The work will lead to the results. The results will lead to the strategic plan. Get on with it." He was really big on clear vision combined with political urgency and really strong partners around the table. And, you know, one of the things I really learned from him when we worked with him in tuberculosis was the importance of having a very narrow technical package, a rather simple technical package, because he always said that public health is so complicated. You need to focus on simple areas or simple packages that are evidence-based, that can be scaled by governments, by partners. Get that right, and then everybody will coalesce around it. And I think his other examples are 3x5. You know, that simple slogan which catalyzed a generation of HIV activists to get people on ARV access. And when I moved into tobacco, I really took the lesson from Dr. Lee around building simple evidence-based packages, having coalitions of partners to support, and really focusing for the governments on the return on investment arguments, because they're interested, of course, in the health impact, but as our first speaker pointed out, they're also interested in the economic impact or the financial return. So in tobacco, we borrowed from Dr. Lee and his work in tuberculosis and said, okay, look at all the things we can do on tobacco. What are the most cost effective? What are the easiest for governments to implement? And we developed something called the Empower package, which is our tobacco equivalent of the tuberculosis package, and since then in non-communicable diseases, which of course are killing the majority of people in the world now. We have focused in WHO a lot of our work on these technical packages. But of course, having the technical package and having the partners is not enough. You've also got to focus on the data and monitoring the results. And that's really important when trying to focus forwards, because it brings a level of accountability. And JWE was very, very interested in accountability. And I'm really delighted to say that since we copied JWE's package for TB, we launched it in 2007. We protected 1 billion people in 2007, and this year we've protected over 6.5 billion people in the world with this narrow package, which is yielding results. So that was something I really learned from JWE.
Brilliant,
Thanks.
many thanks. So you've both mentioned issues around implementation and accountability. And those two key points, I think, are some of the areas in which we need to look to make sure that, how do we monitor to make sure things are happening in those two areas? Well, Dr. Xi, you have the opportunity now to tell us a little bit from your experience and what your perspectives are on leadership in terms of moving from words to action and accountability. And you're very much involved in that, I know.
Thank you. Firstly, I want to really emphasize a country's strong political will and sustained multilateralism are equally important. Although the gap between the commitment and implementation is ultimately about the resources, accountability and ownership at the country level, multilateralism remains indispensable. No single country can address complex health threats alone. Effective implementation depends on coordinated action across member states, international organizations, civil society, and private sector sharing resources, evidence, and accountability frameworks. At the same time, multilateralism must be action-oriented, translating shared commitment into concrete programs, measurable national results. Secondly, I will start with the WHO's role. WHO's Health Emergency Program, established in 2016, now marking its 10th year, has laid an important foundation for global health security. However, WHO regional offices and country offices, the most critical interface between global commitment and national action, continue to have insufficient resources in my mind relative to the scale of threat they face, and this must change. Regional offices and country offices need to be substantially strengthened so that they can provide sustained technical assistance and accompany countries through multi-year implementation process and serve as partners in building national resilience. Based on my own experience in WIPRO for 8 years, a stronger WHO presence at regional and country level is not optional. At the same time, WHO cannot work alone. In today's increasingly fragile global health environment, collaboration with broad network of health partners remains critical. In this context, the outcome of WHO joint external evaluation can serve as an invaluable starting point. providing country-owned, evidence-based assessment that identify gaps, align multi-partner support, and link political commitment into actionable targets that country offices and regional offices can help translate into sustained national progress. Third point is that evidence-based decision-making, robust data systems, and early warning mechanisms should be top priorities for all countries, and declaration of faith on ongoing Ebola outbreaks in DRC and Uganda, and hantavirus outbreak in cruise ship are clear examples. Strengthening IHR, particularly the legal obligations around timely reporting, must be first priority. And equally important is investing in real-time genomic surveillance capacity in LMICs, where many zoonotic spillover events can occur. I had an opportunity to participate in a side event organized by WHO Berlin Hub for Pandemic and Epidemic Intelligence earlier this week, and the hub established in 2021 represents a landmark investment in global early warning capacity. And countries should actively engage with these hubs platforms such as IPSN and EIOS, which together provide the powerful tools for real-time threat detection and data sharing. And my third point is still, political will and country-level ownership must be at the core of any effective public health system. Technical mechanisms only function when national authorities truly commit. A domestically financed national action plan aligned with budget cycles and supported by parliamentary oversight and informed by civil society engagement can transform political commitment into actionable result. And finally, WHO collaborating centers and existing WHO networks must be fully and strategically utilized. As Dr. Jerome Kim presented, Korea has translated its global health commitment into actions by establishing International Vaccine Institute in 1997, Wright Foundation in 2018, and WHO Global Hub for Biomanufacturing in 2023. And Korea's example, as Jerome mentioned, that demonstrate how middle power countries can serve as bridges to resource-limited countries and accelerate capacity building. I believe Dr. J.W. Lee would have been proud to see how far Korea has come as a global health contributor over the past 2 decades, and Korea will continue to build on this foundation in the pursuit of the vision in which he dedicated his life. And let us all work together for health for all. Thank you.
Yeah, thank you. That's a brilliant assessment. Thank you. I think you're absolutely right. I think he would be delighted in many respects with what he's seen, particularly in Korea, but in the world as well, in some of the areas where there's been real progress. But it's not been everywhere, has it? I mean, we had the Sustainable Development Goals, and those have, we're not going to achieve them, I think it's fair to say. And in fact, you don't even hear people. Maybe in tobacco, good news there. But in general, no. And in fact, people have often, you don't hear many people even talking about them now. They sort of almost seem to have given up. How can we restore hope? Because I think a lot about leadership is giving hope. How can we restore hope? Now, you gave the example of the Prime Minister of Canada, and I think his message was one of almost of trying to restore hope. Could you give a bit more on that? Because I think that's really important for us in thinking forward, not just in looking back.
So it's often said that hope is not a plan.
Yeah.
So this hope, or speaking inspirationally, is the first step. And I think that needs to be followed up by something concrete. And this is where Canada, some of the other G7 countries, and other middle power countries should get together and really start to organize, this is what we're going to do. And different countries have different interests. And this is one of the things I learned at IBI. I thought, it's all official development assistance, but certain countries have particular interests, like antimicrobial resistance. Other countries are very, very interested in climate change. The problem is, as with One Health, too often we fragment it into human health, animal health, AMR and climate change, and we don't think across these, the cross-cutting, the things that are cross-cutting, or I think the French people, I call them transversals, but the things that link these things together, I often have difficulty with One Health, actually, because I'm thinking of it from a vaccine perspective. And how do you wrap something together into one big plan that you can speak to a donor or a donor country or a group of donor countries about how vaccines integrate into this much broader One Health concept? And so I think I'd like to talk to you about this afterwards, because we really need to be able to articulate. We're in the middle of our 5-year strategy generation, and Dr. G was actually on our board, so she knows what this process is like. But we're in the implementation phase, and that means that we're going to need to come up with what exactly we're going to do. And it's as Dr. Lee said, yes, you're just going to go ahead and you're going to do things, and the strategy kind of presents itself. So a lot of the things that are now elements of the strategy were things that we started working on 2 years ago, and started generating data, and started putting together teams. And so I think that this is what the leadership is. It's, yes, Mark Carney inspired. Now, Canada and others should start to work together and say, this is what we're going to do, and this is how we're going to do it, and this is what we'll commit to it. And they may not want to commit a lot, but having, and I think everyone who works in global health knows, we never have enough money. Now we have even less, which is even more unfortunate. But are there other ways to do this? Are there people who are willing to step up and say, I'm ashamed of my government. They ought to be contributing more, and my foundation will do this. The Gates Foundation, if you look at the global health funding, it's dropped 15 to 20% across the board. But if you look at the Gates Foundation, if you look at the Wellcome Trust, their commitments have remained. Are there others who might be willing to do that, and are we going to pass a hat for global health? But we're only going to do that if we have a plan. If we can tell them, this is what we're going to do with it. We need to strengthen health delivery systems in low and middle income countries. We have to work on zero-dose children. So I tend to look at everything from a vaccine perspective, so I apologize for that. But, or we need to work on One Health. Why? Because when you look at that map that was just generated, it appeared in Nature about 7 or 8 months ago, where are these diseases going to emerge? And it was odd, because I thought it was going to, Southeast Asia. And Papua New Guinea was a hot spot, and so was Latin America. And again, that's not what we normally think, but it just emphasizes that this is a global problem, and whoever's trying to organize this has got to stop thinking about, well, the only problems are going to arise here, unfortunately in DRC, in the Democratic Republic of Congo, sorry. But we really need to start thinking more broadly about what is needed. We formed organizations almost 10 years ago that were supposed to make sure that there were vaccines. And they've made tremendous progress. I mean, during COVID, they forward-funded organizations. 4 of the approved vaccines came out of this funding. Can we do something like that for Ebola? Can we do something like that around Middle East Respiratory Syndrome, around Nipah, where there are ongoing outbreaks, and we don't yet have vaccines? And so how are we going to think about doing it and being accountable for the funding that we've received to do it?
Brilliant. Many thanks. I think we're having to come to an end. We've run out of time, but let me just quiet and summarize. Well, let me actually do it in a different way. Let's see, if we've been having this meeting in a year's time, and we were here after the new DG had been elected, and that DG was here, what would be the 4 messages that we would want to give to the new DG based on what we've heard today? If I may briefly summarize, I think it would be, we need vision. And that vision needs to be with a clear plan. We need hope and inspiration. We need implementation, and we need accountability. And I hope that that's the message that the new DG, when they come on board in a year's time, is communicating to the world about the future of WHO and the future of global health. But thank you all very, very much for this excellent panel.